right. Thank you everyone for joining us here today. We're going to get started with our How to Build the Best Policies webinar. We're super excited to have a panel here to present to you. So I will let them take that away.
Well, good afternoon, everyone. I think I'm recognizing a lot of faces and names as I'm seeing everyone pop into the Zoom. So I'm excited to reconnect with you. Happy 2023. And if you haven't thought, I know everybody's kind of been in just keep going. We've all been doing the doggy paddle, right? We got to keep going through COVID and make it through and get all the grants done and get everything we can done through all the pandemic. And now we're coming out of it, and great. HRSA and the compliance team and NCQA and all these people now, the extensions are over and they're ready to do your site visits and review your policies, and you're supposed to upload things to them. In fact, I was on the call with HRSA today, learning that even some new regulations that they have and some new things that they're putting into their rules. So I'm going to share that when we talk a little bit later. But today we're going to do our best to hopefully provide you some valuable information about policies and be ready for your policy review, getting you ready for making sure your board gets everything reviewed and having your policies at the best possible. So I'm excited to introduce my wonderful team here. Jonathan is going to talk with you, and he is actually an FQHC lookalike board member, and he has worked at a lookalike, and now he's been working with me. I'm excited for you to meet him. Jeannie, who I've known for a long time, but she worked at a hospital for many years writing policies there, and now has joined our team to assist with policy review and writing. We have Brock, and you may have listened to our CCBHC webinar last month. If not, you can catch that on our website. And Brock is a current CCBHC Executive Director and also a Community Mental Health Center CEO. We're doing both of those jobs right now. And then me, most of you know me, but I ran Valley Professionals Health Center, and then started and ran that for many years, and then ran a lookalike in Greene County, and then have been working with many of you and other FQHCs throughout the country. So we're excited to share our information with you today. So at this point, this is what we're going to go through, why you have to have high quality policies and procedures. And I know this goes without saying, but we can all write it up and do great things, or people try to buy policies. But again, making sure that they are special to your health center and that you're doing everything that the policies and procedures say. And then what organizations really could benefit from policies and procedures. And again, that's any of the healthcare organizations that we're focused on today. Other nonprofits could also benefit, but we are specifically focusing on healthcare organizations. But again, if you are a board member or in your free time, you know, we all have various hats. We're also the Boy Scout CEO or anything like that, or you serve on a board of the local community foundation. Again, feel free to share this with them, because it's good for them to have proper policies and procedures. We're going to talk through administrative and operational policies, what happens when you have inadequate policies. We're going to talk about clinical policies, and then we'll have some time for Q&A at the end. And yes, Hannah is our contact. She'll be emailing the presentation out to everybody that registered. And if for some reason you don't get it or they go to spam, I know everybody has increased their security on email. If you don't get that, feel free to email Hannah or myself. Hannah will put both those emails in the chat for you to see, and they'll also be on one of the ending slides. So at this point, I'm excited to turn it over to Jonathan. Thank you.
Thank you, Elizabeth. That was a great introduction, and I'm really excited to talk to you all today about administrative and operational policies. These policies are essential to your organization because they control the top level, and they often have trickle-down effects in other departments. They cover a wide range of topics: financial management, billing, human resources, your board or governance, IT and privacy, and of course 340B. But the key here is that these policies guide your organization, so to speak. You can go ahead and go to the next slide, Hannah. So here are some of the best practices that we could come up with for you about how to manage your organizational administrative policy. Administrative and operational staff should definitely have sufficient knowledge of policies at your group. If they're not clear, it's probably time for an update or a training. Here's a real story from one of our FQ clients. They were trying to establish a referral relationship with a university-based clinic in Kentucky, and they were dealing with the chief operating officer of this organization, which is an executive role. The chief executive officer on the call could not recall any financial assistance policies or sliding fee discounts that the organization had in place. And as if you're an FQ, you know that billing arrangements with groups that lack these policies are really hard to establish, and it makes things a little bit more complicated. But after the meeting, got to brainstorming with that client, and we were able to find those policies listed for the public on their actual website. So mismatch there in knowledge. Next tip is to designate a custodian and a space for your approved policy and procedures. And notice the word approved, that's an important piece here because it's really common for you to have drafts floating around, especially if you work at a larger organization. You can use cloud storage or physical storage, but I actually recommend that you use both. It just makes it easier whenever you can pick something up and flip through it. And these policies are best developed and managed by teams most of the time, so a co-custodian is sometimes appropriate. And we also recommend that you review your policy and procedures at least annually. This is essential for administrative and operational policy, but we recommend this for all of your policies. This is obviously very labor intense and you have no time already, but a site visit could cost you a whole lot more time and also other things. Annual reviews make sure that you're up to date and that your site visit and inspection ready. You can go ahead, Hannah. Next, you want to develop a means of communicating this policy and procedure information to your staff members and your patients. It's crucial for new and established entities to pass this information along to the appropriate parties. Each employee and contractor with a role or responsibility should know their role or responsibility as outlined in the policy. Administrators often approve policies for other departments as well, so here's that trickle-down effect again. And any cases that are escalated often wind up in the hands of an administrator. And finally, turnover is a big issue for healthcare organizations. It's honestly a big issue for everyone with the Great Resignation, but make a plan for transfer of responsibilities as it relates to your policies and procedures. I want to show you an example on the next slide of an actual site visit finding. So as Elizabeth mentioned, I serve as a board member for an FQHC lookalike. This is an excerpt of the Quality Improvement Assurance Plan, which is technically a policy and procedure. The highlighted pieces are action items that the clinic has signed themselves up for, right? The clinic has to do these things in order to be in compliance with this policy. Since this policy is board approved, they have to do this. There were no issues with this policy until clinic admins were asked about how often QI reports were being submitted to the board. And as you see where the X is, they're required to submit at least 6 reports per year. And our practice, the practice actually only provided quarterly reports, so we only got 4. This resulted in a site visit finding. So this is kind of a silly situation. HRSA doesn't require you to submit 6 annual reports, 6 reports annually. The clinic signed themselves up for this. So if you sign yourself up for it, you have to be responsible for making it happen. Next slide, please. And I'll just include a piece about the 340B program here. This graphic, the data was collected from HRSA's website. You can check the link there. And they actually publish all of their program integrity results for the public to see. the word audit is kind of a scary thing, but it happens. But we do recommend that you conduct internal and external audits and review your policy and procedure on an annual basis so that when it comes time for an actual HRSA audit, we're not going to be in trouble. And you need to document everything about your audits and your policy review process. And that's the end of my slides, and I would love to pass it to Jeannie now. Thank you.
All right. So when you think of clinical policies, what do you think of? And you may think that they're the type of policies that help you guide your inner functionings of your health center. But then if you're like me, if you're a nurse, you think clinical policies and you immediately think, what are some standards of practice that guide the care that's provided to the patients? So when you're thinking of clinical policies, it actually encompasses both of those. It's patient care and then also the functionality of your facility. So one important thing that you must want to do is you want to organize your policies so that they are easily able to be found. And here are some examples here on the right side of the screen that will be popping up, are just some ways to organize your policies. So organization is essential because then your staff members, they can find the policies more easily, and they're able to find the policies that affect them in their day-to-day functioning within your health center, within your clinic. So on the next slide, what's required, and this is specific for patient care policies because I'm speaking to that as a nurse. And so I have on here what's circled is that is the website that shows you the Code of Federal Regulations, and that is specific to Title 42. And Title 42 here in subchapter G, you'll see 491.9 has a provision of services, but in section B underneath that is specific to patient care policies. Now, this is nice because it's very well laid out, and you could even make this into a kind of checklist for your facility to make sure you're covering every single thing that you need. So you want to make sure that your clinic is the services that you're providing are applicable to what your state law says, because you don't want to have any conflicting information there. You also, with those patient care policies, you have to have a group of professional people that are updating, reviewing, writing your policies. And it specifically tells you here in number 2 that you have to have at least one or more physicians. You have to have one or more physician assistant or nurse practitioner, so an advanced practice provider. And then you also need at least one member who's one person who's not a member or a clinic staff member. So at least a minimum of 3 people, a physician, an advanced practice person, and someone who's not a member of the clinic or a staff involved there. Then on step 3 here says the policy must include a description of the services that you are going to provide, but also what services are you going to provide based through a partnership or an agreement. And then nextly, it says that you also have to have policies that show the guidelines for medical management of patients with health problems that include conditions requiring medical consultations and or referrals. You need to show how are you maintaining healthcare records, what are the procedures for periodic review and evaluation of your services that you are providing. And then lastly there, you have to have patient care policies that address how you're going to store your medications or biological, how you're going to handle them, how are you going to administer them. And then in the Code of Federal Regulations, it says that these policies should be reviewed at least biennially, but that's every 2 years. But as John mentioned before, you really want to be doing them at least every year, and especially with patient care policies because clinical practice guidelines change and all of that. So you really want to be on top of what is the best practice of care for your patients. On the next slide, it will talk about what are the common problems that we see when we're looking at clinical policies. So first one is, and these are in no particular order of rank, these are just all the ones that we see. So they're not well organized and they're not easily accessible. So not being well organized means people can't find what they're looking for, or they don't know where to look for them. So that's being the easily accessible. Next, As John kind of spoke to, there's no proof of policy review. So there's no evidence that you have any sort of process related to how you're reviewing these policies. Nextly, you have providers that are not involved in development of policies or in the review of policies. And that's a big one because, as I mentioned on the prior slide, in the Code of Federal Regulations, you really need to have a physician and an advanced practice person helping to be a part of this group that looks at your policies for you. Next is providers and staff. They're not trained on the policies. So be aware of how you educate your staff, how you're telling them about these policies, and also not only just the initial, like your orientation, like with new people, new staff members, but when you have updates to your policies, how are you pushing that information out to them? Next, you can have all the best written policies, as you know, best ever that we've ever seen, but yet your clinic is not following them. So that's another problem we see. Next, you could have a policy that's incorrect or a policy that's missing. And what that means is you could have a policy that's outdated with incorrect information that might have been true a few years ago, but now is no longer true. Or when you go to look for a policy that you should have, you don't have it. Next, it's the whole TDLR, too long, didn't read, right? So you've all read policies that are super long. You kind of glaze over when you read it. So if you have policies that are too long, nobody's going to read it. Nobody's going to know what's included in there. So then they're not going to follow it. You also could have way too many policies and people are just overwhelmed. And again, it's an organizational thing. They can't find what it is they're looking for. And then you may have just a lot of fluff, a lot of unnecessary policies that you don't need. And then lastly, especially when it comes to patient care, your patient care policies that guide how you treat these patients, how you care for them, they don't have any references on them. They don't have any supporting documents. So how do you know that the care that you're providing is the best to your patients? And so just looking at this slide, be thinking to yourself, you know, what do we see with our policies currently within our facilities that we could improve upon? And what kind of problems do we see that may not even be listed? I mean, if you don't have a standard format for your policies, it can be confusing and people can't find what they need within the policy because it's not, each policy is not organized the same within the policy. So staff could be unclear on what policies apply to them. So it needs to be very clear when you're looking at policies on what applies to different staff members. And now I'll hand it over to Brock.
All right, thank you. So I'm going to focus on behavioral health policies and just some of the common provisions and elements that you see in behavioral health, substance use disorder services, along with mental health services in various areas across our nation. So I've got 3 slides here I'm going to run through. So this first one, as you can see, is titled CCBHC criteria. So the CCBHC criteria is a document that's out there by SAMHSA. It is to help guide the certified community behavioral health clinics across the nation that were awarded directly from SAMHSA, as well as some of the states that have established CCBHC certifications. Now, in that situation, if there are an established CCBHC certification, then of course that state's rules will prevail over what should be followed. And if the state does not have CCBHC, but rather community mental health centers still in terms of the public behavioral health sector, then obviously those CMHC state rules will be followed. Things that are outside of the Code of Federal Regulations. But I mentioned CCBHC today because even with private practice, CCBHC is really an amalgamation of the past, the present, and the future. And not just rules and statutes, but best practices. And you'll see hopefully through this slide here. So the first one, for example, except regardless of inability to pay. And actually, Dr. Burrows taught me this back when we were working on an FQHC together. This is the FQHC, Federally Qualified Health Centers creed, that they're going to accept patients regardless of their ability to pay. And you must have a sliding fee set up as well. So this is going to be common for CCBHCs. This is actually in the criteria. This is something they're going to want to see described in a policy. So it's something that will be relevant oftentimes to the federal poverty level and certain percentages. And not just necessarily people that are uninsured, but also underinsured can fall into this as well and be addressed in your policies. DCOs, now this is a specific CCBHC term, designated collaborating organizations. These are partner organizations. And I place this in here though, because many behavioral health entities have partnerships. And so oftentimes it's prudent to have a policy surrounding those partnerships, and even further past the policy, a memorandum of understanding or some written agreement that outlines what the relationship is and what's expected in that. Next is the access to care, and this is becoming more and more common with all behavioral health entities. A policy kind of defining your screening process, what's considered immediate, and this language is taken from the CCBHC criteria specifically, urgent being 1 day. So if it's deemed an urgent situation, that's 1 day of getting in for an assessment. Routine is 10 days. And of course, immediate is getting in that day. That's a crisis. Person and family centered treatment plan. A lot of states billing, particularly for Medicaid, is based off of these person and family centered treatment plans, also known as individualized care plans. They are plans that are established with goals and objectives when a consumer comes in for treatment, and it's something that's going to be vital to all the rest of the services that are being provided throughout their time. Every service will be correlated to that. So having some policy around that is vital, because it's not just your assessment, but it's every service that you're going to provide thereafter. So treatment planning, licensing and privileging. Policies surrounding this are important. Even if you have a med exec committee, they need to have some policies and language surrounding this. Quality and compliance, of course, will be concerned with this, just about how you go through the process of licensing, and also privileging providers when they come on. They may be granted privileging temporarily, or just how that is happening, what providers have that authority, or people in your organization to do that. A lot of agencies, a lot of entities are going to want to see that done. And last but not least, the medical director position. So chief medical officer can be used synonymously with this. And again, this is CCBHC and CMHC specific, but they want to see that position filled and named and have policy surrounding it. Particularly related to their role and their functionality. And if there is not a person filling that position, because as we know, psychiatrists can be hard to find, they want to see some policy surrounding if there's like a loco or someone temporarily filling that role, then what that is, what that policy looks like, and what their role is as well. And I've also linked the CCBHC specific criteria here, because again, there's just a lot of really good information about care and about what that looks like in the behavioral health world, and what that criteria is. And CCBHC is the future of our country. More and more states, double digits now, have CCBHC certifications set up. They're going to just continue to keep coming. And this takes from, though, a lot of the CMHC and what's already existed and best practices to set these up. Next slide, please. Thank you, Hannah. So I also wanted to talk about confidentiality today, because it's very relevant to, of course, healthcare in general, but also behavioral healthcare, because there's some specific provisions that come about. So privacy policy, under the HIPAA guidelines, it's different from what I'm going to mention today, and that's that 42 CFR Part 2. So 42 CFR Part 2 exists to protect confidentiality of SUD or substance use disorder patients by requiring patient consent for disclosure of information by healthcare providers. So you're going to find If someone is diagnosed and being treated for an SUD, a substance use disorder, there's going to be more restrictions surrounding how that information can be shared. There's already overall HIPAA privacy policy, as there should be, guiding healthcare information and the sharing of it, and the recording and storing of it. But if you are a behavioral health entity and you're treating these patients, you need to have policy addressing 42 CFR Part 2, which is that, again, treating people who have substance use disorder services. And like any federal law regulation, it can be considered a living document because it can and it will be amended over time to reflect the environment, like the previously mentioned document with CCBHC, and that criteria that has developed over the years. So just some applicability about the 42 CFR Part 2. Any entity that's federally assisted program is a Part 2 program and must follow this guideline when treating patients that have and fall under that category. You need to get patients written consent before making a disclosure of protected medical records pertaining to the SUD diagnosis. And these are programs federally assisted. It includes if you take Medicare, Medicaid, so CMS programs, as well as entities that receive federal grants, of course, would be included in that as well. And something to mention too, in just the exchange of healthcare information, third-party payers are restricted by these as well and bound by these restrictions. So managed care entities or MCOs, as they are sometimes called, are there. Now, there are some exceptions, and these probably could be included in your policy, but kind of as my colleagues mentioned on here, you don't want to put too much information on here. You want to have enough to guide and to cover, and you may address some of the exceptions if you think they're going to frequently happen and it's prudent, for that, such as medical emergencies, right? Reports of alleged or child abuse or neglect. If you're a mandated reporting agency, that's going to be something you probably would want to include in your policy as well. Also, and in my next slide, I'm going to mention this too, just about Part 2 and law enforcement. Law enforcement organizations must have a court order allowing for placement of an undercover agent or informant within the Part 2 program. And so I'll address that a little bit more too. Next is just about if you're going to be having, actually, we can go on to my next slide here, if you don't mind there, Hannah. Thank you. Okay, so in this slide, I wanted to continue on just that thought of who behavioral health entities are going to specifically be serving, and maybe some of the policies and just things to think about that would be prudent to that are different outside of the rest of the healthcare industry. So SUD, substance use disorder, again, and criminal justice system. So commitment or court-ordered services are going to be something that pop up in the behavioral health world, particularly in relation to criminal justice, of course. And this is something where you probably want to have a policy outlining that process, just the parties involved, the timeline. It's started by a physician, psychiatrist, sent via some staff member, to a judge, scheduling, then next schedules a hearing date. Once the judge, the patient has been committed, what follows, who's storing those documents, what the time frame looks like. I often see the 90-day commitments, and that's important for your entity too, because when they're committed to your entity, that's a responsibility of treating that patient, that consumer, at a high level. So just having that outline, timeline, responsibilities, again, maybe not too specific because you can get more into the procedure role, but it's prudent to have some policy surrounding that. Now, this next one, drug screens, could fall maybe under more of a procedure specific. And if you find, whatever entity you're using, oftentimes they'll have a pamphlet or they'll have some literature on how to use their drug screen. And that can even be included in reference verbatim in your policy, okay? With pictures, I find helps, as well as step 1, 2, 3. For administering those drug screens, which is going to be something that you would have to do often with this population. And so just having a procedure outlined of how to do that, but then also having some policy outlined of, who's doing that, why are they doing it? Even when you get into some of the gender issues, you want to have that aligned about females having drug screens conducted by other females, particularly if it's a urine drug screen, right? As well as males and as other males, and children or minors that may, believe it or not, have to have some drug screens. You have to have some policy surrounding how is that done, and then of course the reporting on that. And then I have just these last two here. Medication-assisted treatment, something we see more and more, and it's a needed service. We're talking Suboxone, buprenorphine, Vivitrol, methadone, often used to treat opioid use disorder. So this is policy related, but you want to have a contract for treatment and a policy kind of related to that, so that those consumers, when they come in, and this could be for a plethora of behavioral health programs, honestly, but having a contract of treatment, they understand, what's the expectation. They're going to agree to medication adherence to help with diversion of medications like Suboxone or buprenorphine. They're also going to agree to the drug screens and come in when they're called, as well as attending those services and what that looks like if they don't attend. And therapy services, oftentimes, that's a great standard of care, and sometimes a requirement of getting the medication in an MAT program and staying in that program is attending therapy services. So having that in the contract, in a policy, kind of outline what that looks like and what that relationship would be, as well as payment, all to just set good expectations for your staff, to have your staff set those good expectations beforehand for your consumers and the people you're serving. And last year, but certainly not least, in the behavioral health world, it's prudent to have an attendance policy. And again, this is something that you're going to use and set those expectations in the beginning. You're going to provide to your staff education and training on how to address this with your people that you're serving, your patients and consumers, to address no-shows, cancellations, what defines a no-show versus a cancellation, what's the difference. This is going to be something to have outlined in your policy and included in the intake packet when the consumers come in for services. And just that if they fall outside of those, there maybe be sent a letter, 10-day letter saying, hey, if we don't hear back from you, you can be dropped to walk-in status, where the patient would then have to walk in for services. So it's another policy that helps with not only regulations and stuff, but also as some of these are here on this page, just your business operations, making sure it's optimal in your day-to-day activities. So, and I'm going to pass it on now to I believe to Elizabeth.
All right, so when I started this company, I really wanted to write grants and set up FQHC lookalikes, which we do. So if you have any interest in those, let us know. And then from there, I've added services based on need. And so we've added some 340B programs if you need assistance with that, with your pharmacy programs. And that's mainly for FQHCs, RHCs, and hospitals. And there are a lot of ways to maximize that, and also to make sure you're capturing all your referral income. We do strategic plans and needs assessments, again, because people have asked us. And then this year we are excited. We're going to start doing policy review for people. And this is ideally, it's just because, hey, we want to check up on all our policies and make sure everything looks good. We're glad to help you with that. Get ready for your site visit. Again, this is really different than, it's not just prepping you for your site visit, but really looking and digging into your policies and making sure that they are what you need them to be for FQHCs, CMHCs, RHCs. Those would be our sweet spots, and CCBHCs. And when I say FQHC, that includes FQHCs as well as lookalikes. And then also developing kind of your board plan for the year to say, these are the things we're going to review each month in the future, because you have no idea how many times I get the call that says, oh no, I have an OSV and I haven't updated any policies for this long. Or, oh no, I know that the reviewers are coming in the next 30 days if you're an RHC and I haven't checked anything in this long. And so this is constant change. And I know with everybody's extreme staffing changes lately, oftentimes you have to look at these policies again and make sure they are up to date. I know that when I was a CEO, I felt like that's all I did was work on policies and make sure they were up to date. And reviewing them. And again, that is a big part of your job to make sure we are in full compliance. As we know, the reviewers are out and about. Privacy reviewers are out again, rural health clinic reviewers are out again, HRSA reviewers are out again, 340B audits are happening again. So we want to make sure you're in the best position possible. Next slide, please. So again, we can help you. This is an example of one that we took that we had before. And then in working with our new nurse consultant, Jeannie, she was able to update that and go ahead to the next slide, update it even from our sample policies and improve it. And there you go, just to make sure, show the references where you got it, showing evidence-based practices. I'm not even going to try to speak to this because some of it probably is over my head. I'm not a clinician, but just making sure that you do have the purpose, why you're doing it, defining things and making appropriate references. As Brock referenced, that's really important in the privacy areas too, making sure that you have the most up-to-date laws. And trust me, it seems as if everything is changing lately. I was even looking at my SF 424 on a grant, and they even updated that last March. And I had to make sure that I had reviewed and had the most up to date because my sample was still from 2020, not from 2022. So again, there have been a lot of changes and you'll want to make sure that you get proper reviews in place. And if you haven't noticed, even when you're writing grants or doing updates, they want evidence-based practices now on everything, or EBPs. I think when I entered this world, I didn't even know what EBPs were for quite a while. And I feel like now that's all you hear on every call. So making sure that you are ready for that. So again, we're here to help you. And we can go to the next slide. And this is just the rest of the policy. But again, setting up review dates, having your calendar in place, because I know if it doesn't get on my calendar, it's not going to get done. So making sure that you have a plan of action, not only for internal review, but also if for certain policies that need to go before the board for that external review as well. Okay. And then again, if you have any questions, we're going to open it up to questions, but I just want to share this as how fast things are changing. Even today, and I'm not making this up, Cassie's on the call and she can attest. I was late to join with on a sales call for a potential new client because HRSA had called me and they told me he said he was reviewing a grant, or actually a budget period renewal I had wrote for a client, which is like a grant or the grant report to make sure they keep getting their status and their funding. And he said, just so you know, we don't really explain this, but now in the certain part of the financial area where you put that you can waive fees, they need specific examples in the policy of why and how you would waive fees. And I said, well, and we talked about the tornado example, which is one that I've given people because one of my FQHC clients had that happen. He said, yes, that's good. But he said, you also need to put job loss. You need to put, life experiences where people no longer have income and things like that, or a pandemic, also for reasons that you would waive fees, and also to ensure the length of time that you would waive fees. And he said, really, HRSA is working on some of their guidance to make sure that they get that updated here soon. So again, I know that HRSA has additional rules besides what they even publish to all of us. Rural health clinics, it's the same way, but just make sure you do have all your policies up to date. If you have questions, feel free to reach out to us, whether you're our client or not. We'd be glad to help you in any way that we can. And if you are interested in anything related to policy review, we would love to help you out. If you saw this and you're like, hey, I need to show this to somebody else at your organization, we will be sending out this recording, and we also will be publishing it on our website. And there are some other videos on our website and a preview. We're starting a YouTube page with some of this. My kids are very excited about that. So you'll be seeing some information about that later in this year where it will have that information. But I did learn, because I had done some grant workshops from someone else who has the Rural Health Clinic YouTube page with Mark Glenn. And I learned a lot of people are looking for grant information, rural health clinic information, and general health clinic information on YouTube. I don't think of that always. I go straight to other methods. But again, that is something that a lot of people look at. So we want to try to be getting our information out as much as possible. As always, we appreciate your time, and we'll open it up now for questions. And Hannah may have received some throughout the workshop. And if not, feel free to email her or put them in the chat, or you can unmute yourself and we'll take those. Thank you. Hannah, do you have any questions?
Yeah, I did receive one. Can you explain what the differences are between policies and procedures?
Who wants to take that?
I'll take that one. And anybody feel free to add in. A policy is the rule, and the procedures are how to follow the rule. Very simple answer.
Yeah, and from
And
the
it used to be
clinical,
the way. Go ahead.
oh, I was just gonna say, from the clinical perspective, I think of procedures as tasks. Tasks that need to have step-by-step instructions on how to do them.
People used to try to do procedures as ways to not be reviewed always by HRSA or the rural health clinic reviewers, but now most of the time when they're asking for documentation, they do put policies and procedures. So that little trick isn't as strong as it once used to be, but I agree with everything John and Jeannie said about those details. But again, now if you look at the site visit protocol or what your reviewers ask you for in 2023, I will bet any money it's going to say policies and procedures.
Elizabeth, isn't there a cool trick for FQHCs that if it's not a policy, it doesn't have to be board approved? Is that a trick that our clients use?
Mm-hmm. But HRSA still may look at it, but yeah, they don't care about all the tasks. Like Jeannie's a nurse, so she cares about all the tasks. They don't care about all the tasks. They just want to make sure the general guidelines are correctly followed. But again, you want to have both of those. And again, can't underscore the importance of actually doing what they say as well.
Perfect, thank you. Another question I had come in is, do you know what are the main issues with policies that healthcare organizations face? I know Jeannie touched on this a little bit in making policies, but do we have any other answers for other issues that healthcare organizations face?
I know the biggest one that I've seen is just people not following what they say. If they say do it monthly, if your policy says do it monthly, make sure it's happening monthly. If your policy says it happens twice a year, make sure it happens twice a year. Go ahead, Brock.
Yeah, that's great. And so I think the thing too, for that I've seen is that updating them, keeping them updated, reviewing them, and just making sure that, again, come along with that you stay concurrent with doing what you say you're going to do, but also, which is often that you're going to review and update your policies. So that's one thing I know is hard to keep up on.
And along with that too, in RHCs, people have binders, and I love binders. And if you worked for me, we always had lots of binders, but now it's harder. And so you want to make sure you're updating all of those binders. And so as you keep getting more and more sites, it's hard to keep things updated. So some people are moving to online systems, but that has different issues. I don't know what the best way is, but again, just making sure that those are updated, because any binder that I've seen recently always includes a medical director. Oh, well, they're no longer there, or a board member that's no longer there, or whatever. So again, just making sure those things are up to date.
If there's any other questions, again, feel free to put them in the chat or go ahead and unmute yourself. No. All right, seeing none, I thank you all for your time today, especially our panel for presenting. Again, like we've said, this will be sent out via email tomorrow. We will send out the slides along with the recording. If you do not receive that, or if you have any follow-up questions, feel free to contact me or any of us that are on the slide here. And again, like Elizabeth said, we've been updating our YouTube channel, which you can find on our website as well.